This is Brad Bevel, Jeffrey Bierman, Cassandra Bills, and Lisa Broll, and we are going to talk to you about manual therapy's effect on low back pain in the pregnant population. Here are our objectives. The etiology is unknown, but contributing factors include hormonal changes, which the release of relaxin causes joint laxity in the SI and pubic joints. Weight gain increases. The increase of weight across the joints changes the center of gravity and decreases the stability of the pelvic girdle. Vasculature. The compression on the inferior vena cava leads to the decrease of cardiac output, blood pressure, and the increase of heart rate, which can exacerbate symptoms. Postural changes include an anterior pelvic tilt, which causes a hyperlordosis of the lumbar spine, leads to additional stress on the intervertebral disc, ligaments, and facet joints that can lead to joint inflammation. Signs and symptoms. Pain is first experienced around the 18th week, peaking between the 24th and 36th week. Pain is greater at night with 67% and in 36% causes sleep disturbances. Chief complaints include radiating pain to the lower extremity, sharp and stabbing, unilateral or bilateral pain. Standing, walking, sitting, lying could be either easing or aggravating factors. Even though it is difficult to prevent low back pain, it is important to educate the patients on proper body mechanics and postures during ADLs. Physical activity before and during pregnancy are important. Light duty and less working hours, and the proper use of seats and cushions.
Rates vary, but most studies agree that at least 50% of women will suffer from low back pain during pregnancy. 1/3 will suffer from severe pain, reducing their ability to perform ADLs and work-related activities, and 1/3 will continue to experience low back pain in the year postpartum. Despite the high prevalence, evidence regarding conservative treatment programs, universally accepted diagnostic criteria, and terminology for this subgroup of patients remains scarce. There has been a lot of debate regarding the risk factors associated with low back pain during pregnancy. Here are a few common risk factors cited in the literature. History of chronic low back pain, history of pelvic trauma, low back pain during a previous pregnancy, and a physically demanding occupation. It is first important to rule out red flags and exclude serious pathology. The therapist should then carry out a thorough history and examination, appropriate tests and measures to differentiate between lumbar pain versus pelvic girdle pain, and then formulate an individualized management plan. Red flags suggest the presence of underlying conditions such as cancer, Cauda-Equina syndrome, infection, or possible fracture, which may be the cause of their pain. Here are a few examples of red flags which should lead to further questioning. If the presence of an underlying condition is suspected, medical referral is warranted.
It is the healthcare professional's duty to be able to rule out other disease pathologies that mimic the symptoms of low back pain in pregnancy. Here's a list of different pathologies that could possibly mimic the signs and symptoms of low back pain in pregnant women. Also, certain conditions that are present before pregnancy may become aggravated, resulting in low back pain. So there are two types of low back pain. There are lumbar pain and pelvic girdle pain. These need to be diagnosed and differentiated early because the treatment is different for each condition. For lumbar pain, the pain is over and in proximity of the lumbar spine. It is above the sacrum, and the pain may or may not radiate to the foot. The paravertebral muscles are tender during the tests and measures, specifically during palpation of the muscles and during movement, and pain increases with certain activities and postures. For pelvic girdle pain, it is 4 times as prevalent than lumbar pain, and it presents between the posterior iliac crest and gluteal fold. The pain is deep, stabbing, unilateral or bilateral, recurrent or continuous, and the pain can radiate to the posterolateral thigh, knee, and calf, but not to the foot, like lumbar pain. Here's a chart of different tests to help rule in pelvic girdle pain and the positive findings. Here's a chart that discusses the sensitivity and specificity of certain tests. Here's a picture of the posterior pelvic pain provocation test being performed. And this is the Faber test. And then here is a picture of the active straight leg raise test. The prognosis is generally considered good. Low back pain declines rapidly during the first 3 months after delivery. However, it can have a high risk of postpartum low back pain, specifically if there's high postpartum weight gain and retention, and if signs and symptoms of depression are present.
Now to go over some of the various interventions and the research behind them. In 2003, Stooge et al. Conducted a literary review and discovered that limited evidence to support the benefits of physical therapy for the reduction of low back pain, the pelvic pain in pregnant population. They concluded that due to low methodological standards and validity measures, it made it difficult to assess the effectiveness of physical therapy, and they made a call for more research with consistent methods and evaluative measures. One of the interventions utilized was spinal manipulative therapy. In 2009, Korsen et al. Found in their literary review that there was limited evidence to support the effectiveness of spinal manipulative therapy in the reduction of back pain during pregnancy. They did consider that the evidence was emergent and that clinicians may want to consider this technique if no contraindications are present. Murphy et al. Also found a 73% reported improvement among participants where spinal manipulative therapy was used as part of a paired intervention program. Hall et al. Reported 2 successful case studies where they used a muscle energy technique in addition to an exercise program. Muscle energy technique is a manual technique which focuses on correcting the sacral torsion and malalignment due to the ligament laxity from the hormonal changes. They also concluded that additional therapy should include posture and positioning education as well as therapeutic exercise. Stooge et al. Also conducted a randomized controlled trial evaluating the effectiveness of a specific exercise program for this population. They had a specific stabilization exercise group versus a control group. They took 81 participants randomly assigned into 2 groups. Both groups received individualized physical therapy, and one group was given a specific set of stabilization exercises. That stabilization exercise group reported statistically and clinically significant improvements in pain intensity, lower disability, and a higher quality of life after the intervention and at 1 year postpartum. Some of the various exercises and home exercise programs that were assigned in the various studies included the stabilization exercises, which were shown to be effective, and those were used to strengthen the deep postural muscles. In addition, some other techniques used were the neuromuscular re-education of the transverse abdominis and multifidus, stretching exercises, and almost all studies concluded that postural training and positioning education were vital to the success of the program. This education included positioning in the semi-reclined position, the use of pillows, and the use of a sacroiliac belt. To sum it up, there is only a limited evidence to support spinal manipulative therapy. Manual therapy has been a part of successful treatments in multiple case studies. Those techniques included the muscle energy technique as well as just general mobilizations. And manual therapy should be followed up by a specific exercise program with stabilization exercises being shown to be the most effective. The bottom line, low back pain is one of the most common musculoskeletal complaints of pregnant women. Early classification and treatment that takes into consideration the individuality provides the best opportunity for the best possible outcome, and this is accomplished by implementing evidence-based practice, which at this point is limited in this arena. That concludes our presentation. Thank you for listening. Here is a list of our resources.